Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about dry eyes, its different symptoms, investigations, and possible managements. We talk about the dry eyes. It is basically a multifactorial disease. Multiple factors are acting on this disease, which leads to decreased tear production or increased evaporation. And these two things, that is decreased production of tears and increased evaporation, leads to the disturbance in the homeostasis of the tear films of the eyes. The clinical features basically of the dry eyes is the sense of irritation. The patient presents with intermittent irritation, itching in the eyes, burning sensation, sandy sensation in the eye. All these things are because of the dry eyes over there. The normal epithelium has been disturbed over there, and the more person rubs the eye, the more he feels irritation. So this thing continues. Apart from this, patient also develop conjunctivitis, redness in the eyes because of persistent rubbing the eyes. And there is also the patient vision is also to some extent disturbed because the tear film is disturbed. Patient may feel glare, halos, or if extreme cases, then there is significant decrease in the vision. So all these things can contribute, and patient can present to us in our clinics. There may be excessive twitching in the eyes, and patient may say that he is feeling tired all the times and lethargic eyes, and these all features can be over there in the patients who have dry eyes with variable grades, and these severities and these conditions will also be of different grades. But usually, broadly speaking, these are the presenting complaints of the patient. We talk about the different components and the composition of the tear film. It consists of the innermost first layer comes the mucin layer. It is high molecular weight glycoproteins, and these are adherent to the hydrophobic surface epithelium, and it's a glycocalyx, and this is the innermost layer of the tear films. To the mucin layer there comes the aqueous layer. This is the largest part of the tear film, and as far as the volume is concerned, it is produced by the lacrimal gland, which is responsible for production, along with the glands of Krause and Wolfrings. And its composition is that contains water, sodium, potassium, chloride, and different antibodies like the IgG, IgA, IgM. All these antibodies are out there. This makes the bulk of our tear film. This is the second layer from the inner side. Third layer is the lipid layer, and it is produced by the meibomian glands of the eyelids. And this layer is basically composed of the sterol esters and wax monoesters. This layer, because of oil and lipids and all these things, is responsible for prevention of evaporation. Yes, its role is to prevent the evaporation of the tears from the eyes. So there are all three layers: mucin innermost, then aqueous, and then the lipid layer. The different photographs of the patient from the slit lamp. In the right side, you will see that apparently the eye looks normal. There is nothing like that, and the quiet eye of the patient, no conjunctivitis, nothing. But the patient presents to us with irritation in the eyes and discomfort. So when we do put fluorescein eye drops and then stain this and see the patients, it shows like this. So it is involving the inferior part and the middle part of this eye and taking stain. And I will request my audience to please concentrate on the tear meniscus inferiorly. This tear meniscus height is also very important, and its shape, whether it is convex or concave. Usually in the dry eyes, because of the deficiency of the tear film, it attains a shape of that green line along the lower eyelid. It becomes more concave pattern. Yes, as shown in this. It is not very high, it is not convex, it is just covering the margins of the lid, the green line along the lower lid and the conjunctiva. Another photograph of the same patient. Here you can see that even the green film is not visible, that along the lower eyelid, and staining is there. Same left eye of that patient. And there are different grades. It is very common nowadays to have dry eye patients. So there are different grades. This is relatively milder than the previous patient, but here you can also see the different, we call these things punctate epithelial erosions, which are staining over there. And the right photograph is without any staining, looks normal, but in the left you can see scattered areas of superficial punctate keratitis and staining over. Talk about the causing factors of the dry eye disease. They are local causes and systemic causes. If we talk about the systemic diseases, rheumatoid arthritis is very important. We should also ask about patient about the Sjögren syndrome. We should take a proper history about the medications being used. For example, he may be using systemic hypertension medicines, antihistamine, antidepressants, some medicines for the acne, which can affect the meibomian glands. Apart from this, his ocular allergic history. And what about the condition about insufficient intake of the vitamins? Sometimes vitamin A deficiency may be there. So all these things can contribute to this dry eye disease. These may be local causes and systemic causes. So proper history is very important regarding these patients. Sometimes anti-glaucoma medications are causing dryness in the eyes. They have preservatives over there which can cause these things. So a proper history is very important. From this, there are different tests which we do. For example, tear film breakup time. We ask to put the dye in the eye of the patient, fluorescein, and then we ask to close the eye. And when we ask him to open the eye, if the first spot of the staining develops before 10 seconds, it means that patient has signs of the dry eyes. This is called tear film breakup time. Then, as I mentioned earlier, the volume, and that different gadgets are available, not commercially, but we can use simply, as I mentioned, on the slit lamp, the meniscus of the tear film inferiorly, whether it is concave, convex, its height, its documentation, pre-treatment, post-treatment. And there is also one test which is called Schirmer test. The strip is put into the inferior fornix of the eye, and after 5 minutes the readings are done with anesthesia and without anesthesia to measure basic and reflex measurements. This test basically gives us an idea about the aqueous deficiency, that is the part produced by the lacrimal gland. So these tests are very helpful in diagnosis, and documentation should be done properly to monitor our treatment. Some basic tests we can also do: the fluorescein staining pattern of the surface epithelium. We can also use Lissamine green dye. We can have a look at this conjunctivitis. Usually it is not specific of a dry eyes, it can be because of allergy or anything else. Tear film osmolarity and matrix metalloproteinases, that can be done for academic purposes in the patients. So these are number of tests which can be done, but they have to be customized according to the available resources and the patient's history. So when we talk about the examination, our examination includes examination of the eyelids, blepharitis, anterior blepharitis, a very important contributing factor to the dry eyes. We should have a look about the meibomian glands. Are they inflamed, red? Is there any material over there? If we do press, sometimes the thick toothpaste-like material comes out. This is not normal. If we have advanced facilities, we can use meibomiangraphy to see the all the conditions of the meibomian glands. After this, there is one term which is called lid viper epitheliopathy. This lid viper is the term applied to the conjunctiva which is along the ocular surface. And because of the friction between the eyelids and the ocular surface, this area which I am telling lid viper, it gets stained with the fluorescein and Lissamine green. Then we should consider and talk to the patient about his blinking pattern. If sometimes a lack of thalmosis there, patient is not closing his eyes properly, and that leads to the persistent epithelial defects over there. So all these things should be done in the examination, from eyelids to the conjunctiva and pattern of closing and meibomian gland study to have a proper diagnosis of the patient. We talk about the complications. The complications depends upon the severity of the disease. If the disease is mild, the patient will present to you with discomfort, ocular irritation, and these things. But if the disease progresses, advanced disease, you may have inflammation of the eyelids, you may have irregular surface, recurrent SPKs, and he may develop infection. Later on, he may develop scarring. All things can happen with this if the patient goes into the advanced stages. Yes. So it is always very important to control the disease in its earlier stages, because once the scarring develops, infection develops, there will be scarring, and scarring will compromise later on to the vision. Yes. I mentioned that the dry eye disease basically causes two things. It causes pain, or it may cause decreased vision. It may be because of aqueous deficiency, or it may be because of evaporation. So we have to control the inflammation, as I mentioned earlier in the treatment. We have to take a proper history, why the patient is developing his systemic patterns and systemic association. That has to be controlled. He is having rheumatoid arthritis, Sjogren's syndrome, all these things to be taken. And then we can go for artificial tears. And it comes in two categories. One is demulcents. These are water-soluble polymers, and its one example is carboxymethyl cellulose eye drops and propylene glycol. Yes, these are basically there to cover up the aqueous deficiency. The second part which is available with us is emollients. These are mineral oil or petrolatum. These are available. These are fat or oil based, and these are basically responsible for the prevention of evaporation. Usually these two broad categories are available. Whenever we are going to start the treatment, we should keep in mind what is the problem, and accordingly we should prescribe the medication. Also, one more factor is the viscosity. Sometimes we have to go for the viscous material which stays for a longer time of duration if the problem is severe. But the viscous medicines, maybe drops or gels or ointment, they are good to retain over there to control the disease, but they ultimately cause some sort of blurring of the vision. Then we have preservative-free eye drops which come in the form of the minims, and the other in the container with the preservatives. Usually benzalkonium chloride is added to these. Benzalkonium chloride is good for the preservation, but it causes more penetration into the eye. Maybe 3.1 times it is causing more as compared to the non-preservatives. Also, it destabilizes the cell walls of the cells. So it is considered, if we have to use up till 5 to 6 times daily, then with preservatives can be used. Yes, but if it is more than 5 times and 6 times we are going for eye drops extensive, then our option should be preservative-free lubricants which come in the form of minims. As the 80% of cases who come to our clinics are basically because of the disturbance of the lipid layer. So if we use the medicines which are having this base, castor oil, light mineral oil, glycerine, propylene glycol, so these help in stabilizing the lipid layer of the tear film. Apart from them, cyclosporine A drops are being used also. They are effective in suppressing the T cell activation and inflammatory cytokine productions, and they also increase goblet cells density. So these also can be used in the treatment of the dry eyes. About the oral medication, we have two types of antibiotics. One is doxycycline and the other is erythromycin. They both have their own advantages. Doxycycline is anti-inflammatory, antimicrobial, and antimetalloproteinase. While if you talk about erythromycin, it is very good against gram-negative bacteria, and it inhibits the pro-inflammatory cytokines. It also increases free cholesterol, neutral lipids, and lysozymes in the meibomian gland epithelial cells. So these both are available, which can be taken orally. Film deficiencies that much that in spite of our all treatment, the things are not getting under control. Then we can go for the punctal plugs. These are the different punctum plugs coming in different colors as per their size. They start from 0.5 to 0.6, 0.7 and 0.8 sizes, and they can be applied to control whatever there is available tears, so that the eye ocular surface is preserved and doesn't get damaged. So there are different sizes which are being shown here in this slide. There are two other sizes of the punctal plugs. Punctal plugs, as I mentioned, they are basically for the reversible closure of the puncti. Anytime we feel that things are getting under control, we can remove them out. Yes, they are very easy to be removed and inserted. And the thing is, they should be avoided in infective conditions and inflammatory conditions because then the inflammation can spread up to the nasolacrimal channels also. And these are easy methods to do the closure as compared to the permanent punctal occlusion, in which once they are closed, then it is very difficult to make the channels open. So these can be tried over there in the patients which are not getting controlled with normal artificial tears and medicines. Along with this, oral pilocarpine has also been tried for the treatment of dry eyes, but it has its own disadvantages, so it is not that much regularly used. When severe cases, when there is minimal fluids over there, so we have to preserve whatever over there is the tears. So these are sometimes goggles are used for the dry eyes. These are protect from the covers from the sides. They protect the direct entry of the air and heat into the eyes, and they maintain the inside whatever the moisture is there. They can also be used, but in the advanced cases whereas there is severe dryness. I want to thank my respected audience for their attendance and attention. I hope this presentation will be beneficial in their clinical practice. Thank you.